Well, our final speaker before we break for lunch is local consultant psychiatrist Dr. John Lane. And after working as a soldier for 10 years in the 1990s and finishing a part-time psych degree, he then completed his medical degree at the University of Tas as an Army-sponsored undergrad student in 2004. He initially worked in acute care medicine and emergency, as well as working in forensic medicine while serving with the 1st Health Support Battalion in Holsworthy until returning to Hobart in 2010 to do his psychiatry training. He's also a crack archer and has coached the Australian team at last year's Invictus Games to a clutch of medals, which was unparalleled, unprecedented perhaps. So please make him very welcome, Dr. John Lane.
Thank you very much, Jane. I'd also just like to thank, the previous speakers. Dave, mate, that was probably one of the best prolonged exposure treatments I've had for a long while. Sitting there listening to that was just really hard. I think what really comes through though is that lived experience, and what I'm going to be talking about today is the losses involved with chronic stress and trauma and some skills-based interventions as a different approach. And what I'm going to start with is talking about some issues that aren't sort of commonly discussed or seen when we talk about chronic stress and trauma treatments. And in particular, I'm coming from a background of a service environment, and by service I mean military, and then, well, I'm still an active duty reservist, but also a veteran of Afghanistan myself. But then the other service occupations, so police, fireys, ambos, that sort of stuff. And Alex raised the point of identity before, and it's crucial. And when we're talking about service occupations, it's not just a job, it's who you are. So when you go home, for example, you take your uniform off, but that doesn't mean you stop being that person. It also sort of highlights some of the culturally specific keys, I think, to really understanding these communities. Because we don't just work as individuals, we work as a part of a team. And then that team becomes a part of a collective identity. You don't work as a police officer, you're a copper. You don't work as a soldier, you're a soldier. These are things that sort of people don't necessarily seem to understand. And a big thing that comes from that is that we become task-oriented because we get our value from what we do. And so what you do then resonates very strongly with your sense of self and reinforces that same sense of self and identity. And so what you end up with as people is people who are task-oriented and task-focused. And from this, we get our sense of meaning and therefore a sense of purpose. Sorry, a sense of purpose and therefore a sense of meaning in our lives. And this becomes fundamental to identity because when you no longer have a purpose, you're no longer fit for function, you lose your sense of meaning in your life as well. And that's something that you lose from chronic stress and trauma. But we don't talk about that. And my question is, why not? As we heard before from James, 10 foot tall, bulletproof. Yep. And then as we heard from Alex, well, hang on a sec, look at the cognitive dissonance there. The classic, way of looking at that is called fifth syndrome, and that stands for in the head, as in fucked in the head. Because if I've got these things, how can I be that? Yep. How can I be 10 foot tall and bulletproof and be a defender and protector of society and doing all these things if I'm like this? And that cognitive dissonance between what I was and what I am now, I think, is something that we actually don't necessarily address, and then how we move forward with actually treating it as well too. Because what happens is that when you start to become stressed and your bucket starts to fill up, then you develop a whole bunch of maladaptive coping mechanisms. And in particular, one of the things that we don't necessarily talk about is the way that we're conditioned within service environments. And when I'm talking about conditioning here, what I'm saying is that emotions get in the way of doing your job in a service environment, going to a nasty MVA, having to actually take someone out of a cell, if you're a corrections officer. Doing all these sorts of things means that emotions will interfere with and impact on you and your ability to do your job. So we're conditioned by nature of our jobs and our training to suppress our emotions. And again, as you've heard from the lived experience stuff, anger is one of the key emotions that is socially acceptable. And so anger is something that you see expressed. But what happens when you start to lose, your purpose and your meaning in life because you're no longer fit for function? And so, again, from the lived experience stuff, what you've heard is there's so many different losses that come through. And so you get the social withdrawal, you get the isolation, you get all the other sorts of things that compound the deficits in chronic stress and trauma. And this is just, it's quality of life issues with PTSD, but again reinforces the losses and that spiral of loss that occurs with chronic stress and trauma. So this is from the 2017 Nature Review on PTSD, and it's probably one of the best summary articles you'll be able to find on PTSD, so I highly recommend that. What you're seeing from this, though, is that as a person with PTSD, or the triumvirate of anxiety, depression and PTSD, things spiral downhill and spiral out of control. And what you're seeing here is a loss of function. And when you have a loss of function, by definition, you have to lose your employment, but you lose all these other elements within your life as well too. Quality of life deteriorates. It has to, because as you heard from Dave, how can you function when you're in that sort of headspace? As you heard from James, if that's what you are like day in, day out, of course you can't function. And again, in a service environment, anger is one of those emotions that's socially acceptable. And anger is obviously very closely related to hyperarousal and hypervigilance because it's a defensive emotion. Anger, the purpose of anger is to help us defend ourselves, protect ourselves from potential threats. Now, if all you can see are potential threats, then funnily enough, you're likely to be angry for a long time, a lot of the time. Going back to those emotions and those sorts of things, you can see that the issues that you're surrounded by here are pervasive all through your life and can become dominant within your life. This sort of suggests that potential interventions definitely have to relate to things like emotional regulation. And there was an interesting article just released late last year, early this year, on difficulties with emotional regulation within the US military, and talking about a whole bunch of areas where emotional regulation was the key to the development of a range of different mental health disorders. And so anxiety, depression, obviously PTSD, but then the maladaptive and avoidant coping mechanisms, which can then be obviously substance abuse, so drinking is a really common one, and drinking is and has been socially condoned within these cultures for a long, long while. It's how do you deal with problems? Well, you hit the pub and you all get shit-faced drunk. Yeah, because then it's socially acceptable and it's okay to talk about things, but you can't do it any other time. You also see the avoidance behaviours, and so coping strategies tend to be avoiding emotions and avoiding overwhelming emotions in particular, and so then compounding problems, because the further and further you back away from functioning, the worse and worse your life is going to be. So looking at this, emotional regulation in terms of the capacity to maintain yourself, in terms of self-identity and in terms of functioning, is obviously a key area when we're talking about the general level here, not the specific level of treatments for PTSD, but the general level. That, however, requires social integration, because no man is an island, and the worst possible punishment that we have for individuals in our society is to put them in prison, to isolate them from the rest of society. If you are in prison, the worst possible punishment you can have there is isolation. But this is what we do, this is what happens when you have chronic stress and trauma. Because you isolate yourself in order to protect yourself. You withdraw from society and you withdraw from the potential positives that you can get from relationships. And as you heard again from Dave, relationship breakdowns occur. Well, gee, I wonder why. If all you've got is anger and you're pushing people away as well as actively withdrawing, because of your own mental state and your own poor functioning, then, relationship breakdowns are all that's going to happen. It's the loss of purpose and meaning though too. And, again, from the lived experience perspective, feeling like life isn't worth living because what's the point? You're no longer 10 foot tall, you're no longer bulletproof, you're no longer fit for purpose. So what's the point? And what are you going to do when your whole self is invested in being that other person? A copper, a soldier, or whatever else. So when I came back from Afghanistan in 2013, I fell into a huge heap, and I couldn't, as a clinician, I couldn't really get help or treatment for myself because people just didn't understand. And I was lucky enough to get a Churchill Fellowship and went to the States in 2015 looking at, interventions for military and veterans, and, caught up with a bunch of colleagues that I served with. And at the National Centre for PTSD in Palo Alto, I came across the STARE program. And this stands for the Skills Training in Affective and Interpersonal Regulation program. And I ran that in 2016, I think for the first time in Hobart, and with the guys from Mates for Mates. Can you stick your hand up? A little bit higher, come on, don't be shy. So Brendan, the guy in the high-vis dress shirt there, that's bloody awesome, mate. I tell you what, I take my hat off. No way I'd have the balls to wear that. But seriously, Brendan can tell you more about his experiences within the program. So I've been running that as a part of my PhD through the Centre for Traumatic Stress Studies in Adelaide for the last couple of years, and we've had about 130 participants go through. So 12 90-minute sessions, so weekly sessions for 12 weeks. And it's been very effective. However, the STARE program itself wasn't developed by people with lived experience and didn't contain or doesn't contain any of that sort of information on self or the conditioning effects of service and all the other sorts of things that go along with it. And so I've redeveloped it and am running a clinical trial of the Group Emotional and Relationship Skills program starting next year. And so this will be in Adelaide with the road home, and so that's military veterans, police, fireys, ambos and all that sort of stuff. And then again in Hobart, Brisbane and Townsville with Mates for Mates. But again, the important things here are the focus on self and the focus on functioning. And this particular program, same with STARE, does not deal with specific or individual trauma in any way, shape or form, because the idea is behind this program is that it's functional, and so it's based on recognising that stuff has happened to you, but then what are you going to do moving forward? How are you going to manage those problems that you've got in all the different domains in your life and move forward to being more functional? Which is why it starts with the individual and emotional regulation and looking at psychoeducation on what happens, how it happens and why it happens, and then what we do to compensate for it, which doesn't necessarily help us. But also, the range of different interventions that you can have. So as you can see here, what we're talking about is a psychological toolkit. So CBT, DBT, ACT, all the TLAs that you can think of to chuck in a bucket that you can actually use to help yourself in different situations, to keep yourself moving forward and being functional. Second 6 weeks, though, is all about relationships. And again, as I said, relationships are fundamental because as a clinician, I can treat someone that has PTSD, but if they have no friends, no family, no support, am I ever actually going to get them better? I don't think I can, quite personally, because if you can't maintain healthy relationships, then you are going to be screwed, basically. Yeah, because you can't live, you can't do things, because we are social animals, full stop, end of story. But when we're talking about the relationships, again, it's important to recognise how that sense of self and identity comes through into those relationships and how the norms of behaviours and the values that we bring into our relationships affect us as well too. Also looking at particular conditioning effects such as power dynamics, because again, when you talk about service environments and service occupations, there are strict hierarchical power structures. And so that has an impact, not just on how you behave, but on the potential for chronic stress that you've been exposed to or trauma, including sexual abuse. Looking at conflict and conflict resolution is really important, and most importantly too, communication skills, and effectively communication skills. Because communicating to your partner that you're angry with them, by using a bunch of swear words and then storming off, isn't the most effective way of resolving conflict. But it's what happens when you're in that state of stress and distress that you heard Dave talking about. The final session then talks also about looking at the changes in self and identity and in functioning over the course of the 3 months. And that 3-month period is quite important in terms of actually developing and establishing behavioural change so that you can move forward. So the structure of GEARS itself is I think, somewhat different, and I'd like to think that this is a novel approach within Australia, let alone internationally. I think the key factor with GEARS is that it's peer facilitated. And as you've heard from previous speakers, moving through that journey of trauma and then to post-traumatic growth is actually really, really important. And having that lived experience in order to be able to understand what's happened and why it's happened and how it's happened, and then give that back to the community that you're a part of is really, really important. It's also very important though to have this operating in a structured format, and hence you can't just have peer counsellors. There has to be accreditation or training standards, go way back, so selection and then appropriate training, accreditation, and then ongoing supervision and monitoring. And so the idea behind these sorts of peer-led programs is that they're actually integrated within the organisation. And so in Adelaide, for example, I've got 2 fireys who'll be delivering these programs for the fire brigade. I've got an ex-copper who's delivering these programs to military veterans and police and fireys and other people. I've got an army chaplain. I've also got an army PR major as well too. The common denominator though is the lived experience, and then the formal counselling training by means of a certificate or something else similar, and then ongoing supervision for delivery. The GEARS program can't be a standalone program because it's adjunctive to mental health treatments. Ideally, these sorts of skills-based intervention programs should be run before formal treatment, or at least in conjunction with or concurrently with current treatment as well too, because you can't say a program like this is going to fix everyone. What I'm talking about here is functional skills-based interventions that help people live, and not actually talking at all about specific treatment for depression or anxiety or PTSD. But when we look at our mainstream treatments for those conditions, we often tend to forget the individual, and hence the reason for these sorts of programs. Most importantly, the program needs to be run in a group format, and group format for service occupations is so important because that's how we operate. It's how we're trained and it's how we operate. So it's culturally appropriate. Using peers allows people to actually bounce ideas off each other, and it normalises maladaptive behaviour, and it normalises stress and struggling. But then it also normalises appropriate coping behaviours and appropriate things that actually help you to move forward. Using peers as the peer counsellors as facilitators then models this sort of thing. And it just creates that sense of identity, again, because you're within that group environment. The particular specific environment might be somewhere completely different, like a Mates for Mates centre, but you're with people that have done the same thing that you've done and been there, done that. And so you understand each other. And so the groups come to, a level of cohesion very, very, very rapidly, and then improve as they go along. And Alex was talking about a similar effect with the program that she was running for VicPol. I think one of the other things too is that being in a group challenges that tendency to avoid, to withdraw and to isolate. It normalises particularly the huge sense of shame and guilt that everyone has about their lack of functioning and about what they were versus how they perceive themselves now. And this is really, really important, because when you start to talk about the moral injury spectrum, acceptance of what's happened and forgiveness of self, it's never going to happen with a clinician on a one-on-one basis. Yeah? Because, again, shame and guilt tied directly to identity. And if your identity is as someone who is wrong, who is guilty, who needs to be ashamed, then no amount of talking at you will change that. It has to come from within. And hence the reason for these sort of factors, I suppose, being primary in the particular program. And then when that sort of stuff can get expressed in a group environment, without rejection and without criticism, it sticks and it stays. So finally, from the hard sort of perspective, I think what we've got here is the skills and the psychoeducation that are delivered on an ongoing basis to change the attitudes and behaviours of the individuals that go through. Then people can go and get the specific treatment that they need. But they've got a whole bunch of skills and a whole bunch of knowledge in order to be able to actually get the best treatment for themselves, but more importantly, make the most of it. So I think the loss model is something that the loss model of PTSD is something that we don't discuss enough. You know, you've heard about it here today, again and again and again, from the people that have actually been there. It's important though, because when we're talking about an individual, we're talking about a person, not just a person who has PTSD. Yeah? And if I can't, or if we can't help that person grow and function, then we're not actually going to be able to manage their PTSD properly. And hence this might be a slightly different paradigm here, but I think it's something that needs to be developed and to go forward. In many ways, the preliminary data from the STARE participants that I've had have come through have actually been incredibly positive, because, you know, I've had one guy, for example, who said, and again, a Vietnam vet, who said, in 20 years of seeing shrinks, no one's ever told me this shit. Why? You know? And so making something that's culturally appropriate and helping people understand themselves allows them to function better. And when we function better, we have lower distress. When we have lower distress, we have less anxiety, less hypervigilance, less other symptoms of our disorder. And that actually goes across to the physical symptoms as well too. And, you know, Dave in particular talked a lot about the physical symptoms of PTSD. And some of the research being done at the CTSS, for example, is coming across really clearly from the big study called the Transition Wellbeing. I can't remember it. TWRP. Yeah. Anyway, is showing that, you know, using computer modelling, you can actually predict who has PTSD by looking at the clusters of physical symptoms that they have. So, you know, the mind and the brain and the body are obviously very, very closely linked. And so managing emotional stress and distress by improving functioning can lead to similar outputs on physical functioning and physical distress as well too. I don't think you can do it at this generalised level though without having people with lived experience, because again, it's that personal aspect that has to come through to say, yes, this is what's happened, but this is what you can do about it and how you can move forward. So yeah, so I think that's pretty much it from me at the moment, but I think I've got a couple of minutes for questions. Yeah. Oh, that's awesome. Thank you.
Thanks so much, John. Well done, everyone. We get a koala stamp for wrapping up our morning session. No doubt, I trust you've heard some pretty astonishing commentary and statements and facts, statistics shared with you all here today. Do take advantage of the lunch break. If there is a question that you would like to present to our panel session, which is just after 3:30 this afternoon, there is a box on the registration table. But we will break for lunch a wee bit early. Hopefully they'll cope with that. So please enjoy refreshments and everyone's company, and we will be back at 1:30. See you then.